Welcome back to another psychiatry lecture. I'm Sam Asgharian, and now we'll be discussing substance related disorders. For the exam, it's important to know that not only do you need to have a strong understanding of the physical manifestations of intoxication from certain substances, but you also need to know the symptoms involved when a person is withdrawing from those substances. So, the first thing we'll discuss is intoxication with a specific substance. It's a reversible experience. The substance leads to either psychological or physiological changes. What you need to note is that once the substance is discontinued, you're no longer intoxicated, but you might be victim to withdrawal symptoms. The withdrawal symptoms come from cessation and or reduction of a substance, leading to either psychological or physiological changes. So what you need to note is that sometimes withdrawal from one substance can actually mimic intoxication on another substance. The vignette is going to clue you in on important details that let you know what it is and most likely what the diagnosis or the treatment options are. So that's intoxication. And again, someone doesn't have to be using a substance for a prolonged period to become intoxicated by a substance. Abuse is different. That's a maladaptive pattern of substances that leads to engaging in hazardous situations, legal problems, inability to fulfill obligations, and ultimately a continued use despite adverse consequences. Those are the hallmark signs of substance abuse. So with drug abuse comes drug dependence. Here it's again a maladaptive pattern of substances that leads to tolerance. That's the big one. You need stronger and stronger doses to get the same effect because you're tolerating the drug better than you were at first. And ultimately, if you try to cut back or completely cut off from the substance, you get withdrawal symptoms. The patients spend a great deal of time engaging in drug use, and they continue to use it despite adverse consequences. Here you can see a good picture of alcohol dependence. Ultimately, right, alcohol withdrawal is a major physiological event that needs treatment. If you're a medical student, I remember from my time, I definitely had caffeine dependence and ultimately those blistering headaches of caffeine withdrawal. So it's any substance that leads to those types of symptoms and those types of issues. So we briefly mentioned alcohol. Let's talk about alcohol intoxication and withdrawal. So when you're intoxicated with alcohol, what you see are a talkative, sometimes sullen, sometimes friendly, then moody, and ultimately disinhibited person. The treatment for alcohol intoxication is mechanical ventilation if it's severe. For severe alcohol intoxication, you can see someone undergo respiratory distress. They can't actually breathe for themselves. And on the exam, note that in a vignette, alcohol dependence can occur at any time. It doesn't have to be just someone who's a college age student. You can have an elderly individual who's maintained decades of alcohol dependence, and ultimately they might go through alcohol withdrawal. And those you'd see signs of tremors, hallucinations, seizures, delirium tremens. It's when the hands start to shake. So what you note is you treat that with benzodiazepines, thiamine, multivitamins, and folic acid. A word to know is formication. It's the feeling of tactile hallucinations. It's when you feel insects crawling on your skin. That's another very strong sign of alcohol withdrawal. Now note too that this is extremely similar to abuse of the psychogenic drugs, LSD, mushrooms. You might see someone hallucinating. It could also be signs similar to schizophrenia. But ultimately, you'd look for clues in the vignette, especially the delirium tremens or the tactile hallucinations that would lead you to a diagnosis of alcohol withdrawal. Moving on from alcohol, we'll discuss the uppers, amphetamines and cocaine. So what you'd see in intoxication here, the signs and symptoms, these people are moving at 100 miles per hour, or at least they feel like it. So you'd see euphoria, hypervigilance, autonomic hyperactivity, weight loss, pupillary dilation, and perceptual disturbances. You would want to treat these patients with antipsychotics and or benzodiazepines and or antihypertensive depending on all of their symptoms. You want their blood pressure down and you want their heart rate down and controlled, so you want to treat those issues. What if they're abusing amphetamines and cocaine and they start to undergo withdrawal? Now you would look for anxiety, tremulousness, headache, increased appetite, depression, and a risk of suicide. They feel terrible. It's a huge drop in their feelings. They're very, very high. They've got those uppers going when they're on amphetamines and cocaine. So it significantly affects them when they come off of amphetamines and cocaine. So you treat them with bupropion and or bromocriptine. Those are the two you want to go for when you've got a person withdrawing from amphetamines and cocaine. It'll calm and sedate them and ultimately decrease their anxiety. And here's a fun one. Every time you tell someone that you're a physician, they always ask you if you can prescribe them something fun, and usually they reach for the cannabis request. So we'll talk about cannabis. There's really not much here to be tested on, but you need to know what it does do and what it doesn't do in order to eliminate it when it appears as an answer choice. So when you're intoxicated, the signs and symptoms, remember, this one's fun. So you get impaired motor coordination, slowed sense of time, social withdrawal, increased appetite, and conjunctival injection. The treatment is none, right? They'll just immediately at some point come out of it and go back to their normal state. You're not worried about overly intoxicated cannabis users. For withdrawal, none. I told you it was an easy one. So there's no treatment, obviously. So again, note what this does if you're not familiar with it so that you don't choose it as an answer choice when it's not going to be the correct answer. We talked about those psychogenic drugs. So these drugs activate serotonin receptors, the hallucinogens, so you can treat them with antipsychotics since they block serotonin. Hallucinations are very key to narrowing them down on the differential. So what you note most importantly are those perceptual disturbances, those tremors, incoordination, dissociative symptoms. I told you the intoxication with these drugs is very similar to withdrawal from alcohol. So you would treat with antipsychotics and or benzodiazepines if they're acting overly aggressive and or talking them down, calming them down, and putting them in a better state of mind. For withdrawal here, again, none. So it is pretty easy. If there's no withdrawal, there's no treatment. So note that's what's going on in hallucinogen intoxication. So we'll discuss inhalant intoxication. This isn't as high yield as some of the other substances, so we'll move through it pretty quick. For the intoxication, you'd see belligerence, apathy, aggression, impaired judgment, stupor, or coma. So you do want to treat this, so you'd use the antipsychotics. However, there's not going to be withdrawal symptoms. You don't build up a dependence to these. If there's no withdrawal, that means there's no treatment. So a very high yield topic is opiate intoxication and withdrawal. So for opiate intoxication, remember opiates are the opposite of amphetamines and cocaine. They're downers. So you'd see apathy, dysphoria, pupillary constriction, drowsiness, slurred speech, coma, or death. There's a very high mortality risk with overdose from opiates. And what you do is you treat with naloxone. Naloxone will prevent the binding of the opiate to the receptor and allow the person not to feel the severe respiratory distress that might occur from overdose and intoxication. Continuing on with the high yield topic of withdrawal, what you'd see here are the flu-like symptoms: fever, chills, lacrimation, abdominal cramps, muscle spasms, diarrhea. Withdrawal from opiates is severe. It's very difficult on the person. It's a harsh process. And so you want to help them. You treat them with clonidine or a longer acting opiate, methadone, there to basically bridge them from cutting back to ultimately cutting off. You can also use buprenorphine as well, but methadone and clonidine are the two big ones to know here. And another fun one, it's not fun for someone who's on it or someone dealing with someone who's on it, but its symptoms are rather fun. So here you've got a great diagram of someone who might possibly be intoxicated with PCP, phenylcyclidine. So intoxication signs: belligerence, psychomotor agitation, really big one here, violence, nystagmus, hypertension, seizures. Law enforcement officers hate having to respond to calls where someone is intoxicated with PCP. They're overly aggressive. They're strong. Their pain threshold is much higher than it is when they're not on PCP. So you do want to bring these patients down. You use antipsychotics and or benzodiazepines and or talking down. You really want to make sure they're calm and sedate, because otherwise it's a very difficult situation to handle. For the withdrawal from PCP, there isn't any. So really the big one to note is intoxication and the treatment of PCP intoxication. So another good one, and I want you to look very closely at vignettes that mention high school or college athletes who are very large in size for their age. It's going to be from anabolic steroid use. And when you do use these, you want to note the signs and symptoms are irritability, aggression, mania, psychosis. Not really fun, right? And that's where the term roid rage comes from. It's people who are on these anabolic steroids and they can't control their emotions and they're too strong as well. So you want to bring them down with antipsychotics that calms and sedates. That's a theme that keeps repeating itself in psychiatry. You too want to watch out for the withdrawal symptoms, depression, headaches, anxiety, increased concern over the body's physical state. They're used to being much larger, and when their body starts to regress or atrophy, their muscles do, they become very upset. And so the treatment here is to prevent them from becoming depressed, and that's to give them SSRIs. So something you do want to know, especially for both step 2 CS and CK, is the CAGE test. If you suspect someone is an alcoholic, you ask them a series of 4 questions. 2 positive responses leads to a positive test and indicates that further assessment is warranted. So the C is, have you ever felt you should cut down on your drinking? A is, have people annoyed you by criticizing your drinking? G is, have you ever felt bad or guilty about your drinking? And the eye opener, E, is, have you ever had a drink first thing in the morning to steady your nerves or to get rid of a hangover? Answering 2 of those with yes or more with yes leads to a positive CAGE test. So how do you prevent someone who's dependent or abusing something from doing so further on? You detox them. It's a period of 5 to 10 days, mostly in the hospital or inpatient setting, to assure that it's safe. The body undergoes a lot of physiological and psychological changes during this time. After you've detoxified them from the substance, you rehabilitate them. That's usually a period of 4 weeks or more with a focus on relapse prevention techniques. Alcoholics Anonymous, Narcotics Anonymous, those are important places where people get support for the detox and rehabilitation stages. You can also prescribe the medications. That includes disulfiram. That's an acetaldehyde dehydrogenase inhibitor. That means that the person can't break up a byproduct of alcohol and they get extremely sick. They'll vomit, they'll feel awful, their head will hurt majorly. So disulfiram is an example of aversion therapy. The person is subjected to something aversive, vomiting and nausea, to deter them from undesirable behavior, drinking alcohol. You can also add, for Narcotics Anonymous, someone on opioids, naltrexone. That's going to be an opioid receptor antagonist. And just note, acamprosate is another one, but really disulfiram is a big one to note for the exam. So our lecture wouldn't be complete until we applied our knowledge on a case. We've got a 65-year-old engineer suffering a femur fracture and some cuts and bruises after being involved in a motor vehicle accident. He's admitted to the medicine floor and started on oxycodone. The day after admission, he appears confused with observable tremors in both extremities. He becomes concerned about bugs on the walls in his room and asks for your help. So what's our question? What is the most likely explanation for his symptoms? So basically, it's an extremely common scenario. An otherwise normal seeming patient, 65-year-old, he's an engineer, just a simple motor vehicle accident. He has symptoms during his hospital course. And so you can basically start to think, is it possibly alcohol withdrawal? A brain concussion wouldn't lead you to think that the day after admission he would feel that way. Oxycodone intoxication, remember oxycodone is a downer. You wouldn't expect this confusion, tremors, and that bugs on the wall feeling of hallucinating that he has. There's nothing that says it's schizophrenia. Remember the timeline for schizophrenia. So B, alcohol withdrawal, is our correct answer choice. Note the timeline. He probably needs alcohol on a daily basis. He's admitted to the medicine floor, and obviously you know that he's not going to have access to alcohol. So the day after, he starts to feel the symptoms of alcohol withdrawal. It's not the other ones due to timelines and other issues that prevent it from being brief psychotic disorder and or schizophrenia. That wraps up our case and another great psychiatry lecture.